In this lecture, we will review hematopoietic agents, also known as growth factors. Please review the relevant vocabulary. As you can see, there are quite a few for this lecture. The objectives are listed on the slide as well as in the Blackboard module. Let's begin by reviewing hematopoiesis, which is the process by which our bodies make red blood cells, white blood cells, and platelets. This process is regulated in part by growth factors, which are naturally occurring hormones that stimulate the proliferation and differentiation of hematopoietic stem cells, and they also enhance the function of these cells when they're in their mature form. These factors cause colonies of mature blood cells to form when in the lab setting, so they are generally called colony-stimulating factors, or like I said, growth factors. So either of those names you may hear in clinical practice. All of these drugs have three names. In practice, you probably will hear all three used interchangeably. The first name is the biologic name. This is kind of akin to the chemical name when we talk about other drugs. They have a generic name and then, of course, a trade name as well. And this is a chart from your text. It's on page 656. So you can see there are three groups of drugs that we're going to talk about. The erythropoietic growth factors, the leukopoietic growth factors, and the thrombopoietic growth factors. And on this table you can see the biologic name, the generic name, and the trade name listed. Now we won't go over all of the generics that are available. We will use a prototype from each group. But nevertheless, I want you to recognize that they all have a biologic name, a generic name, and a trade name. Let's briefly review some pathophysiology. You can also refer to your textbook for a very brief review, but I would encourage you to take a look at your pathophysiology textbook that you used last semester if you feel you want a more in-depth review. So you can see that all of these cells start out as a blood stem cell, and then they differentiate. So some of those blood stem cells become myeloid stem cells, and the myeloid stem cells can differentiate into red blood cells, or platelets, or myoblasts, which also ultimately become white blood cells. Or on the other side of the picture, you can see that some of those blood cells become lymphoid stem cells, ultimately lymphoblasts, and then again white blood cells. So you guys know there are quite a few different types of white blood cells. That's why the path ultimately that leads to white blood cells could either come from the myeloid stem cell line or the lymphoid stem cell line. One thing to point out is that this machinery resides primarily in the bone marrow in adults, and it requires a constant supply of three essential nutrients: iron, vitamin B12, and folic acid, as well as the presence of hematopoietic growth factors. And these are proteins that regulate the proliferation and differentiation of hematopoietic cells. Inadequate supplies of either the essential nutrients, which I don't have pictured on the slide, but just keep in mind if we have inadequate supplies of either those nutrients like iron or B12 or folic acid, or the growth factors, then ultimately we could see deficiency of any of these functional cells. So that's about all I'm going to talk about. When we talk about the individual drugs, you'll see kind of where they act within this process. So let's talk about the pharmacology. So I mentioned that there are three categories that we'll talk about. The first group, the erythropoietic growth factors, these affect red blood cell production. So erythropoietin is the biologic name. Epoetin alpha is the generic product that will serve as our prototype, and that has two brand names, either Procrit or Epogen. The second group, the leukopoietic growth factors, affect the white blood cell production. So our biologic is leukopoietin, and that would be granulocyte colony stimulating factors, or GCSF. In practice, you'll hear that referred to a lot as GCSF. And then the generic name is filgrastim, and the brand name that will serve as our prototype is Neupogen. And then the third are the thrombopoietic growth factors, and those increase platelet production. And so our biologic name is interleukin 11. Oprevalkin is the generic, and Numega is the brand name. So we'll go over each of these three drug classes. Let's start with the erythropoietic growth factors. Before I talk about the drug, let me just kind of remind you the role of erythropoietin, which is the naturally occurring growth factor hormone. It is a hormone that stimulates the production of red blood cells in the bone marrow, and you can see from the picture that it's produced by the kidneys, and that is done in response to anemia or hypoxia. So for some reason, the patient's experiencing anemia or hypoxia, some factors that can lead to anemia or hypoxia: low blood volume, anemia itself, of course, low hemoglobin, poor blood flow, pulmonary disease. Those are just some of the factors that decrease tissue oxygenation that triggers this increase in erythropoietin. And erythropoietin will stimulate the hematopoietic stem cells to differentiate into red blood cells. And by the way, erythropoietin has other actions in the body, but we're not really going to talk about those. Really, for our purposes, we'll talk about the role of erythropoietin in regards to stimulation of red blood cells. Our prototype erythropoietic growth factor is epoetin alpha, and the brand name is either Procrit or Epogen. This drug is produced by recombinant DNA technology. It's a glycoprotein. It has essentially a protein component that is identical to endogenous human erythropoietin. It stimulates the production of red blood cells just as human erythropoietin would. And they're also called, by the way, ESAs. So specifically, this drug class are also called ESAs, which stands for erythropoiesis stimulating agent. And that's because, the way they work, they increase the production of red blood cells. They are used for anemia of chronic renal failure, so that's the primary use. And this is helpful for patients with renal failure because it reduces the need for transfusions in these patients. These drugs take about 1 to 2 weeks to work for the initial onset of effect to be seen, and generally the full effect is seen within 2 to 3 months. They also are used for chemotherapy-induced anemia, specifically for non-myeloid malignancies, so malignancies that aren't starting in the bone marrow. They also reduce the need for transfusion in these patients. Generally speaking, though, we only use these drugs for cancer patients that are receiving palliative therapy. And then finally, they're also used for patients who have HIV who are taking zidovudine or AZT. Now, when we talked about patients that were HIV infected and that were taking zidovudine, I said that one of the main adverse effects associated specifically with zidovudine, so it's not a class effect, it's just zidovudine, is anemia. And that's one of the reasons why we rarely see patients getting zidovudine these days. But if there is a patient that's on zidovudine and they're experiencing anemia, then this therapy could be used, and it has been shown to be effective. All right, and then finally, anemia in patients facing surgery. So if the patient is scheduled for surgery that significant blood loss could be anticipated for, and they're anemic, then that would be potentially an indication for this particular medication. So for the most part, this drug is pretty well tolerated. It is only given via the IV or sub-Q route, so not all patients are comfortable with that. But nevertheless, it is well tolerated, with the exception of hypertension. Hypertension is the chief adverse effect that is seen with this medication. The other adverse effects that I have listed are cardiovascular effects, or DVTs. So you should make a note. Generally, those effects are not seen when the drug is used correctly. Those are adverse effects that we see with improper use. So cardiovascular events like thrombotic events like stroke or MI, heart failure, cardiac arrest, those might be seen, or also or DVT in patients that are getting surgery. And what it comes down to, especially for the cardiovascular events, is that this drug causes hemoglobin to rise. That's the whole point of using it. But when hemoglobin rises too high, so if it exceeds 11 grams per deciliter, or when the hemoglobin rises too rapidly, so it rises over the course of a week or 2 weeks too rapidly, that's when the patients are at risk for these cardiovascular events. So monitoring is very important for these patients to prevent cardiovascular events. In reference to the DVT, patients who are anemic, who are going to have surgery that could potentially have a lot of blood loss, this drug could be used. The problem is when it's used and the patient does not have adequate anticoagulation, they're at risk for DVT. So in that setting, it's recommended that they get anticoagulation. Individual variation. So for cancer patients, they can have progression of tumors. This drug can shorten survival and it can increase death. And that's why I said we don't use this drug in all cancer patients, just in patients that are receiving palliative therapy for the most part. Renal patients in that population, I mean, that's who the drug is used for. But what we worry about is that their hemoglobin rises too high or too quickly. So we have to monitor very closely for that. And like I said, with pre-op patients, it's important that they have anticoagulation on board to prevent them from experiencing a DVT. So in terms of nursing implications, monitoring, star it, circle it, highlight it. Monitoring is very important for patients that are on erythropoietic growth factors. First of all, blood pressure is monitored because, like I said, this drug can cause hypertension. Additionally, hemoglobin and hematocrit should be monitored closely. We like to keep that within the range of 10 to 11. I have 11 bolded on the slide because when it gets to 11, that's when we start thinking about maybe the drug needs to be discontinued, because if it goes above 11, those are the patients that would be at risk for cardiovascular events, as well as a hematocrit should be kept below 33%. Keep in mind that these patients may need iron supplementation, B12, or folic acid supplementation. Many times these can be provided through a multivitamin, which I have abbreviated as MVI. Especially in the inpatient setting, you'll see MVI used as an abbreviation for multivitamin. So keep that in mind, that it wouldn't be uncommon to see these patients taking a multivitamin or even maybe more other forms of iron supplementation. All of these patients have to receive a risk evaluation and mitigation strategy medication guide. Remember, the REMS program is operated through the FDA, and it is in place for drugs that have the potential to cause harm if the drug is not used properly. I told you the biggest issue with this drug is that in some patient populations, it can increase mortality when it's not used correctly. So when you're educating your patients on this medication, one of the things that you would do is provide them with a REMS medication guide. And then finally, if you're drawing this up, which I don't think is common, usually in the inpatient setting, the pharmacy would draw it up. But if you're in the clinic setting, then you probably will be drawing this medication up. And if that's the case, you have to be careful not to shake or agitate the vial, because this drug is a protein. And when you shake proteins, it can denature the protein and cause it to not be effective. So let's move on to the leukopoietic growth factors. These are the granulocyte colony stimulating factors, or GCSF as we generally call them. The prototype that we'll discuss is filgrastim. and the brand name is Neupogen. So the leukopoietic growth factors essentially are a drug that is identical in structure and action to the human granulocyte colony stimulating factor, or GCSF. This hormone is produced by monocytes, fibroblasts, and endothelial cells in response to inflammation and allergic challenge, suggesting that GCSF has a natural role in helping to fight infection and even cancers. This drug is also made via a recombinant DNA technology. And like I said, it's identical in structure to the human endogenous version of GCSF. So a lot of times this is referred to as GCSF. In practice, I'm sure that that's the term you'll generally hear for this medication. It's given to reduce the risk of infection. So that's the whole point of using GCSF. In specific patient populations. So patients who are on myelosuppressive chemotherapy. So many types of chemotherapy suppress bone marrow, and that causes suppression of neutrophils. Now, we are cautious. If the patient has a type of cancer that originates in the bone marrow, we generally won't use this medication. But other types of cancer that originate outside of the bone marrow, when we're giving them chemotherapy that suppresses the bone marrow, then we might use that to increase the neutrophil count. Also, for patients that are going to have a bone marrow transplant, those patients are obviously at risk for neutropenia. Some patients have severe chronic forms of neutropenia that are unrelated to the administration of chemotherapy or cancer. So for those patients, this drug could also be used. And there are some investigational uses that are kind of quite common. So zidovudine-induced neutropenia, for example, that drug's been around for a while. Like I said, it causes anemia as well as neutropenia. So it's not an FDA-approved use, but that is, certainly a use that is possible for the GCSF. And then is also harvesting hematopoietic stem cells for transplant is another investigational use. So the bottom line is that this drug is used to reduce severe neutropenia. It increases neutrophils. It reduces the chance of infection in these patients. It reduces hospitalization, can reduce the need for IV antibiotics as well. The trade-off, though, is that it's very expensive. It's also only given via the IV or the sub-Q route. And by the way, that's because these drugs are proteins and they're not absorbed. And even, even in the GI tract, they are degraded in the GI tract, so they're not absorbed. For the most part, this drug really doesn't have a lot of adverse effects, especially when it's used short term. But with long-term use, we do see bone pain. About 25% of patients will experience bone pain that's mild to moderate. Generally, it is relieved with Tylenol, which is good. Some patients might need opioids, though. Splenomegaly is another potential adverse effect, as well as leukocytosis. And again, these three adverse effects are generally seen mostly with long-term use. Leukocytosis, it occurs in about 2% of patients. It's generally seen when we use high doses of the leukopoietic growth factors. It's not harmful per se, but we generally try to avoid it. In terms of individual variation, so patients with, or cancer patients with their disease originating in the bone marrow, we generally do not use this drug. If it is used, it would be under very cautious consideration, but generally speaking, we don't use this drug in those patients. Nursing implications, so clearly white blood cell counts should be monitored with this medication. Because it's given subcutaneously, the patient should be educated on how to administer it, and that would go, and really that's true for all of the drugs in this lecture. They're all given sub-Q. If the patient has to administer them in the home setting, we would want to provide education for that. And then just like the first drug class we talked about, these drugs are proteins, so if you are drawing this up, You don't want to shake or agitate the vial because you don't want to denature the protein. Okay, and the last drug class we'll talk about are the thrombopoietic growth factors. Interleukin-11 is the biologic name. Oprevalcan is actually the only one that's available in this class is Oprevalcan, and that's the generic, and Numega is the trade name. These drugs are also made via DNA recombinant technology, and like I said, interleukin-11 or Oprevalcan is the only one that's on the market. There are other drugs that act kind of similarly to these, but they're pretty new, and they're not drugs that you need to be responsible for your NCLEX. So we're not really going to talk about those in this course. So like I said, these drugs are produced by recombinant DNA technology, and they are structurally similar to the hormone that is naturally occurring in the body that stimulates the production of thrombocytes, which are basically platelets. These drugs act on platelet progenitor cells and increase platelet production. And so basically they stimulate the proliferation of hematopoietic stem cells and megakaryotes, progenitor cells, and this increases the synthesis of megalocytes, which ultimately become platelets. They also induce the maturation as well. So they work within about a week. The peak action is about 7 days. And they're used essentially for patients who are receiving myelosuppressive chemotherapy with the goal of minimizing thrombocytopenia. So essentially these drugs decrease the need for platelet transfusions. Really that's kind of the only setting where we would see these being used. And they're also given by the sub-Q route like the other two drugs that we talked about. This one, however, is not given via the IV route like the first two are. So some adverse effects. This drug can actually cause some pretty significant adverse effects. The main adverse effect we worry about is fluid retention. This drug causes sodium and water retention by the kidneys, which can lead to peripheral edema, obviously plasma volume increases. It happens pretty quickly after the drug is started, usually within just days. It can also cause dysrhythmias. It's not exactly understood how this happens, but it's thought that it's related to kind of expanded fluid volume. And the drug can also cause severe allergic reactions. So for any patient that has signs of allergy like rash, urticaria, flushing, fever, low blood pressure, chest pain, wheezing, shortness of breath, edema of the face, tongue, or larynx, those patients, the medication would be stopped and it would not be restarted. In terms of individual variation, again, because these drugs act on the bone marrow, if the patient has a cancer with disease that originates in the bone marrow, we wouldn't use them. Additionally, if the patient has a history of heart failure and they're on diuretics, it's not a good idea to use this drug because of its propensity to cause fluid retention. Or if the patient has pre-existing dysrhythmias, that would be a major concern, and probably the patient would not receive this medication. Some nursing implications. Obviously, monitoring platelets. So to get platelets, you need to get a CBC. So we would monitor CBC with platelets. We'd also monitor electrolytes and fluid status because of that propensity to cause retention, as well as signs and symptoms of allergic reaction. So patients should be educated on those signs of fluid overload as well as signs and symptoms of allergic reaction, and they should be instructed to call their provider immediately if they experience those. Again, this drug is a protein, so we don't agitate or shake the vial. And like I said, patients should be educated on those signs and symptoms of fluid overload, as well as allergic reaction, and then how to self-administer the medication. All right, and that's it. So if you have questions about the lecture, please post them to the discussion board. I do have a quick case that we'll briefly review. So you have a patient with chronic renal failure. He's been prescribed epoetin alpha. The patient asks the nurse why this medication's been prescribed and when it will start to take effect. What do you think the most appropriate response by the nurse would be? So you could pause the tape for a moment, think about that, maybe write down some thoughts, and then restart the tape and I will review what I think is the appropriate answer. Okay, so hopefully you had some time to think about that. So you guys know that we use this drug specifically in patients with chronic renal failure who have anemia because of its ability to reverse anemia and to stimulate red blood cell production. It doesn't necessarily eliminate the need for transfusions, but it will, in most cases, substantially reduce the need for transfusions. So that's what you would tell the patient as to why the medication was prescribed. In terms of when it takes effect, or when effects generally will be seen, in most patients who have chronic renal failure, who are on dialysis, or even those who don't yet require dialysis, but have anemia, the initial effects are usually seen within just a couple weeks, maybe 1 even to 2 weeks, and the maximum response is generally seen within 2 to 3 months. So obviously it's also important for the nurse to assess lab values, right? So pause the tape for a moment and think about what lab values you would expect to monitor for a patient on epoetin alpha. Okay, so hopefully you had a moment or took a moment to think through that question. I hope you said hemoglobin and hematocrit. Those are very important to monitor for numerous reasons. One, we monitor them to assess therapeutic effect. But number 2, we also monitor hemoglobin and hematocrit because if these levels rise too rapidly or if they rise too high, then our patients are at risk for cardiovascular events. Additionally, for therapy to be effective, I told you guys that iron stores need to be adequate. So we also could monitor transferrin saturation. So this is a lab that is monitored to assess whether iron stores are adequate. Now, I didn't mention this in the slides, so this is not something that I would necessarily test you on. But in doing these cases, we try to go a little bit more advanced. So transferrin saturation is something that we would look for. We would also look at ferritin concentrations, and these, if they are low, then we would need to restore these with iron supplementation prior to starting epoetin alpha. So again, that is a little bit more advanced than what we talked about in the lecture, but something to think about. But you definitely need to know that we have to monitor hemoglobin and hematocrit. All right, and the last part of our case. The nurse teaches the patient the most common adverse reactions to the medication and methods to prevent complications. What are these reactions and preventative methods? So please pause the tape for a moment and think through that part of the question. Okay, so hopefully you took a moment to think about what common adverse reactions could occur with epoetin alpha and what you could do to prevent those complications. So specifically in patients with chronic renal failure, the thing we worry about most is increased blood pressure. And the extent of hypertension is directly related to the rate and rise of the hematocrit. So to minimize this risk, we monitor blood pressure closely, and if necessary, the antihypertensive drugs may be adjusted. Now, patients with chronic renal failure in many cases have pre-existing hypertension and most likely will be on antihypertensive medications. So, like I said, we monitor that blood pressure closely and potentially adjust those antihypertensive medications. In some cases, the hypertension may not be, it might not be possible to control it even with increased doses of antihypertensives. So in that case, the next step would be to reduce the epoetin dosage. And again, this is, maybe a little bit more advanced management stuff, but just stuff for you to think about. So, when you're talking to the patient, you want to let them know, yeah, your blood pressure might go up, and the provider might be adjusting your blood pressure doses. And if that doesn't work, then they might be changing your epoetin alpha dosing. The other thing to keep in mind is that you want to give these patients a medication guide, right? The medication guide is going to have a lot of detailed information about hypertension specifically, monitoring blood pressure, and kind of what the provider might do in that scenario. All right, so hopefully you guys absorbed that information, but if you have questions, please feel free to post them on the discussion board. Thank you for listening.